I'm going to present you shortly the second case, short case history, after which we are going to connect the angio. This is very young patient, 53 years old, male patient, who did present some days ago in our clinic with angina on exertion. The patient had a subjective feeling of being very much limited in his everyday activity, with risk factors for coronary artery disease, as arterial hypertension, dyslipidemia, and he's current smoker. In sinus rhythm with normal repolarization and nothing specific from echocardiography, preserved ejection fraction without any kinetic disabnormality and valve function. This is the angio of the patient. You can observe some angulation of the ostial LAD. We did observe 20 or 30% stenosis without any other significant disease in LAD in mid-second and distal part, as well as circumflex artery. Right coronary artery is dominant artery without any epicardial disease.
Okay, so obviously this is a typical ANOCA patient. Can we connect with the cath lab? So, hello guys again. I hope that you hear us. Unfortunately, we don't hear you.
We hear you now with a handheld microphone. We will do it like this. So you're right, this is a young patient with chest pain, which is very suggestive of angina. There is indeed an ostial lesion in the LAD, but very, very, very moderate. It's barely visible. Maybe we can have a look to these shots again. So you see that the ostial lesion is a little bit pinched. Here in the cath lab, we also see very discrete calcification. So definitely there is atherosclerosis in this vessel. You see the small tapering of the ostial LAD, but the rest of the vessel is angiographically at least very, very smooth. And while waiting for you, Valérie already did two things, namely a fractional flow reserve measurements, and we will show you the vessels, the tracings here. If you could show yeah, that's ideal. That's ideal to have both side by side. That's fantastic. And this is the fractional flow reserve, and very surprisingly, and in contrast to the previous patients, here we have a FFR of 0.79. You will say, well, it's not very different, but okay, nevertheless, psychologically, it's important. And then we went to a pullback, which is illustrated here, and which shows, and look how important it is to do this pullback. It shows a very progressive disappearance of the gradient from the very distal LAD to the proximal left main. So it is not per se this ostial lesion which is the problem, but it is probably this diffuse infiltration of the coronary artery which is responsible for a small pressure gradient. Now, this is where we are. There is no real target for anything to do, and we will take advantage of having this patient on the table to demonstrate how we and many, many other people are taking measurements for the microcirculation. So we have to switch gears and focus a little bit. So we are not going to go in the epicardial vessel anymore, but we are going to focus on the microcirculation. Now, we can do a lot of things with this pressure wire, because we have to realize that, maybe you can keep the foot on the scopy, just to show where we are, that you see the guiding, it's an ABU6 French, and then we have the pressure / temperature wire, because we have to realize that the sensor, which is there at the junction between radiopaque and non-radiopaque part of the wire, is very sensitive to pressure, but also to temperature. It's a fantastic thermometer. And we are going to take advantage to perform two things, and to try to demonstrate two things. First, bolus thermodilution. Are we ready with bolus thermodilution? And continuous thermodilutions. These are two applications of the general indicator dilution theory, but you will see they are quite different. They provide us with some different approaches, but I believe that both are complementary and that the future is in these measurements based on the Abbott pressure/temperature wire. So just to focus here on the table, maybe you can show the room. Is it possible to increase the insert that you have there on the screen and to put it bigger? If not, leave it like this. It's not a big problem. What might be interesting, Frédéric and Adriaan and Dobrin, is to make a poll in the audience to see to what extent people are used to bolus thermodilution. So, did you ever?
Okay, let's. Valery shows that it is sometimes not so easy to do bolus thermodilution because it should be flushed very fast, and with the same saline you cannot use in this case the assistive device for the flushing. You have to use the same saline solution from another syringe.
Okay, good.
For initial flushing.
This monitor on the screen over there.
Yes.
Because the temperature should be the same.
Okay.
Or very similar. Yes.
Maybe a show of hands. Who in the room has experience with doing bolus thermodilution?
I will tell you, because in Bulgaria there are only two systems. One is what you see and another is in our center.
Okay.
Just
it doesn't
to be clear, there are only two places.
So not a lot of people.
Yes, unfortunately, this is why I'm a little bit going into the detail, because a lot of audience expect my fellows who are not here. They were in the morning, but now they are missing. I don't see them. But actually, except them and Valery's fellows, the rest, this technology is new for our country. We are doing for almost 2 years, but for the rest of our colleagues, they are not familiar with the technology and for the methodology. So this is why I'm a little bit more in detail, and it would be good to explain in more detail what and how.
Yeah, Dobrin, this is the intention. We were about to go step by step towards bolus thermodilution. And for those who are missing the things here, well, they have to know that there are many lectures where these details will be repeated during the afternoon. So, bolus thermodilution, as the name tells us, is a recording of the temperature after injecting a brisk bolus of saline at room temperature, which means colder than the blood, in the guiding. And this is what we are going to demonstrate. We will do that 3 times at rest and then 3 times after hyperemia. And I would like to suggest to start, because the patient is waiting on the table. We have to zero the temperature, so Tabo is going to do that. Yeah, okay. Temperature is 0, and when you are ready, you just tell us, and you tell us what you are doing.
Okay, ready? We should start the program.
Yes.
And it is very intuitive, and it leads you through the.
Okay.
We're making 3 milliliters of saline.
You don't have to do that. Oh. Yeah. So we have a first thermodilution curve. I will discuss the details afterwards. You can repeat, inject now. It's written on the screen, inject now, so we just inject now. And you have 2 values which are written there on the screen in the yellow square. Okay, inject now. This will be the 3 measurements performed at rest. So we have 3 values, 188, 116, and 116. I would suggest to replace the 188 because it's really out of range. And if you have another value syringe for us. You do it a third time, and we will replace actually the 188 by a new value. Good. So 124, 116, 116. That's very nice. We are very close to each other. And actually what we see here is the average mean transit time. And when I say mean transit time, it means the time which is needed for a red blood cell to go from the guiding to the distal part of the LED. That is the mean transit time. So the longer the transit time, the lower the flow. The shorter the transit time, the higher the flow. It's very simple. It's not rocket science. And this is the reason why we are going to do that at rest. This is at rest. These values are relatively long. And we are going to now induce high premium. So I let you do. Okay, you can induce high premium. Please go. And we are going to induce high premium again with papaverine. And the machine will ask us whether we injected papaverine, or am I wrong? Okay, inject now. Okay, you can go. I think you can go. Yes,
Inject.
you can go. Yeah, go. Okay, so you see already a thermodilution curve, which is much narrower.
Maybe you should repeat.
Wait a minute.
Should click again.
We have, okay, we have plenty of time. We have induced hyperemia, so click here. Inject now, you can go. We are still hyperemic, there is no rush. Inject now, again, you can do it. And then we are waiting for the third time. When we will be done with the third time, we will have the average. Okay.
Inject.
I already see that we made a small mistake, but okay, that's not a problem. Yes? Go? Okay. Let's pause here. For those who have never seen that, it's a little bit difficult to follow, but this goes very fast, and you see that the method is very, very fast. But anyhow, we are here with hyperemic values at rest and hyperemic, mean transit time at rest and mean transit time during hyperemia. Now, please do not pay attention to the changes in values that we have seen, but actually to obtain a coronary flow reserve, we have to divide these times by these times. We made a couple of small mistakes by not being well synchronized, Valérie. So what I would suggest is to repeat everything once. We have time, there is no reason to rush, but it's better to do it well, okay? So we are going to click and save this recording and to go live again, and I would propose to repeat everything. So we need 3 times a bolus at rest, and I will tell you when to do it because the patient is still probably a little bit hyperemic, so we can zero the temperature again. Okay, whenever you want. We are ready to inject at rest, and Valérie is going to do that. And you see that the thermodilution curve, which appears here, is already much broader than what we have seen. It's relatively similar to inject now, yes? Okay, that is one. That is a second one. Relatively close, reasonably close. Inject now, yes?
Papaverine пригответе.
Okay. Not too fast, the papaverine, because
Just to be prepared.
And now we have, wait a minute now, we have the 3 mean transit times, and the average is 1.18 seconds. The machine asks us now to induce hyperemia. This is what you are going to do. No. So when you have injected hyperemia, papaverine, you tell us. So, and this again can be done with adenosine IC. Okay.
I'm ready.
Okay, wait a minute.
Okay.
Now I can click. And now we are going to wait for a
Yes.
stable signal. Yes, I think you can inject now. Go. And look at the morphology of the thermodilution tracings. You see the traces in blue. Inject again. You see these tracings? They are very fast, very narrow, completely different than what we have seen. And we will stop once you inject. Okay, that will be a little bit longer. And we are going to stop. Click and save. We can click and save. Okay, so let's think a bit on these tracings. You have data at rest, you have data during hyperemia. Blue is at rest. You see that the mean transit time is much longer than during hyperemia. This is at rest, this is hyperemia. In other words, during hyperemia, there is an acceleration of the flow. That's normal. There is an increase in the flow, so the red blood cells are going much faster. To what extent this acceleration? 4. A factor 4. This is the coronary flow reserve. It means that the flow has increased probably by a factor 4 as compared to the baseline flow. Now, another index which can be derived from these tracings is what we call IMR. It's the index of microvascular resistance. And this index is here, is obtained, and we will go into the details later, is obtained by multiplying the distal coronary pressure by the hyperemic mean transit time. This hyperemic IMR, this index of microvascular resistance, is also normal. So we have two values which are really very reassuring. This is borderline normal, I would say, and this is frankly normal. So this is, in a nutshell, I know we are going fast for those who never saw that before, but for those who have done that 2 or 3 times, they understand that very well. This is bolus thermodilution. I would propose to stop here for a second, because if there are questions in the audience or questions in the panel, it's the moment. And in the meantime, you can give the reflow catheter and everything for continuous
Catheter.
So give us a couple of seconds, because now we are going to switch from, again, bolus thermodilution to continuous thermodilution, and the people here have to install the injector. Now, in 2 words, or in a nutshell, again, the difference between bolus and continuous is that in bolus thermodilution, we take a syringe of 3 cc, 4 cc, we inject the bolus briskly through the guiding catheter. This is made by hand, and you can imagine that if you do that by hand, there is somehow an operator interference. Continuous thermodilution, as the word tells us, is a continuous infusion of saline by an injector through a dedicated catheter that we will position in the proximal part of the left coronary artery, in the proximal part of the LAD in this case. Again, we will try to explain that more in detail this afternoon, but we are going to try to at least demonstrate that for you right now. To do this, we need, of course, a pressure temperature wire. We need a dedicated catheter, which is called the reflow catheter, and we need an injector, not a regular infusing pump, but an injector, which is here, which allows us to deliver 10 and 20 milliliter per minute. 10 and 20 milliliter per minute in the proximal part of the LAD. So I don't know if you can see and if people can follow what is happening here on the table, but Valérie is flushing the reflow catheter. We are going to connect this reflow catheter.
Probably you should explain that it has 4 holes, which
I will try. But
do you see this?
Yes, we see it.
You see the 4 jets?
Yeah.
It's a dedicated catheter which perfuse saline through 4 lateral jets. We are going to again.
Валери, сложи го на една бяла марля да се види как се промива, защото се видя по-хубаво.
Дръж само.
Okay, good.
Ранички, включи го на 10.
Yeah. Could you? Yeah. So Tabo is going to
Puznigo.
activate the pump simply manually, and you see the flushing of the catheter. Do you see that on the camera?
Yes. Yes.
Okay, that's fine.
We
That's
see it
important to
clearly,
understand for the people, because the 4 holes are intended to allow perfect mixing. You have to eliminate all this. To perform perfect mixing of the saline with the blood. Again, we are going slowly because first, it's their first time here in the lab. Second, for educational purposes, we try to go step by step. But in our lab, it takes exactly 1 minute to be ready, up and running, and the whole measurements take another 4 or 5 minutes. So it's not much longer than bolus thermodilution. You can put this ray flow catheter, which is a monorail catheter, over the wire, over the pressure wire. And while flushing, you can advance the ray flow catheter, keep the wire, yes, you can advance the ray flow catheter in the guiding. So, and once you are 20 centimeter in the guiding, Tabo will stop flushing, because then we know that there is absolutely no air bubble. Then I will ask to the nurse, you to connect the pressure wire again with the remote transducer, the wireless transducer, and Valérie will advance. I repeat, this is all their first time. So I'm very impressed by their skills. Okay, you're almost there, Valérie. So now you are going to...
So maybe one comment for the audience to make it perfectly clear. There are 3 ways to assess microvascular function invasively: bolus thermodilation, continuous thermodilation, and Doppler. This patient already had bolus thermodilation. We saw it live, and we could, I mean, in my cath lab, for example, we don't do continuous, so we could stop there. But for this specific demonstration, we're going to use a second method. So we're going to do 2 times the evaluation of microvascular function with 2 different methods, just to show you what we can do in different ways.
Снимам.
Okay, that's good. Thank you, Frederic, for these details. Do you see...
микрофона, професор Сянус.
No, George is...
Okay.
Yes, the Doppler wire. Yes, flow wire.
No, the flow wire does
Yes.
not exist anymore, so it
That's
will...
why I'm asking, because
Exactly.
I know that it doesn't exist, and then the question about because it was updated like the flow. We were doing CFR back in 2000, 20 years ago. Is it still valid?
No, the Doppler flow wire is not commercially available, and I heard rumors from Philips saying that probably this year it will be available again. So,
that's
but
great.
this is something we have to keep in mind. It's a fantastic tool, but if not available, it's not really fantastic. Now, please keep your foot on the scopy. We are going to show where the marker is. The marker is in the LED, but it can be put even more proximal. Pull back, please, and please give a test. Give a test. It can be very proximal, even a little bit more, a little bit more. Why is it important? Yeah, okay, test.
Тест.
Fantastic. Good. We are all set. We have the sensor of the wire which is in the distal part, and the saline will be given in the proximal part of the LED. Now, we on our side have to go to the, let's say, the capability of the system to measure absolute flow. It's written absolute flow, so it's available on all the Corventis. That's not a special license, it is available. Okay? We also, and that's very important, have to zero the temperature. What? Yeah, I think it is fixed. I think it is well fixed.
The flow.
No, it is well fixed. So
This, should we
yeah,
change
but
this?
that is not that important. Okay.
Okay.
You're right. Okay, Valerie is observing that we have to program everything to have a right flow rate. But let's go step by step. So everything is there, and now actually the machine, the pump, is ready to infuse 10 milliliter per minute of saline at room temperature in the proximal LED. And I will draw your attention to what happens on the screen. And look specifically to this blue line. The blue line is the temperature. So why not to start first recording? I will record. You agree? I record, and now I ask to Tabo to push on the button and to start the pump. If you can see that the pump is now delivering saline at 10 milliliter per minute. Please keep your foot on the scopy. And then you will see that the numbers here are going down. Why is this? Simply because the sensor feels, oh, what's going on? It's getting a little bit cooler there. Why is it getting cooler? Well, of course, because we are giving saline in the proximal part of the vessel. And you see that the temperature goes down and down and down and will stabilize after approximately 30 seconds. And we are going to be very patient because we like to have nice, clean tracings. And during all this stabilization, it allows me also to give the following explanation. Look at the PDPA on the screen. Did not change at all. It means that we are definitely not inducing myocardial hyperemia. We are still at rest. I see the nurse understanding very well what I say, so thank you very much. So we are at rest. And now it's really stable. We are minus 0.3. That's what we are used to. Tabo will continue infusing, and I will ask Valérie, I did not warn you, but Valérie, you are going to keep your foot on the scopy and pull back relatively fast. No, not the catheter, but the wire, the sensor. Keep the catheter in your hand so that the catheter will not move. Yeah. Okay, and it's a little bit counterintuitive. You take the wire out
into the
and you put the sensor just on the marker. 1, 2, 3. Okay. Stop there. And look what happens on the screen. Look what happens on the screen. The temperature has declined no longer to minus 0.3, but to minus 3.5 or 3.6. This is the temperature of the saline when it enters the coronary artery. Okay? Why when it enters the coronary artery? Well, because we are in the middle of the flow of the ray flow there. And here we are actually done, and I will ask Tabo to remove his, to stop the pump. And you see that the pump is stopping. And what do you see with the temperature? It goes up. And it goes up, and it will go up to 0. Almost 0, you see? And when it reaches 0, we are all happy because this means that there has been no drift. That is 0, and I can stop the tracing. Now, that is it. That's it. That is not more difficult than that. And the only thing we have to do is to make sure that the measurements are not performed in a turbulent area, but in a very stable area, and we need all the elements to calculate absolute coronary flow at rest. And let's go to the screen. That is the temperature distal. Do we need this? Yes, for the calculations. But let's focus immediately on the results, because the calculations, the equations is difficult to do and to explain without the support of a slide. Here we have a flow of 133 milliliter per minute at rest in the LAD in a young gentleman. This is a strictly normal value. And please note, I say at rest. How do you know it is at rest? I'm sure it is at rest because the PDPA here and the PDPA here are exactly the same. So this is 100% correct. Flow 133 milliliter per minute. Resistance 717 Woods units. You remember the good old Woods units in the pulmonary circulation? Well, these are the same Woods units, except much, 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 much higher because the flow is lower. And you are going to say, yeah, but so what? Resistance, flow, you told us this morning, this is influenced by the mass. Fully agree. But this is at least what we have addressed. And this is the reason why I will ask Valérie to go back with the wire, endoscopy please for the demonstration, to the distal part. We are going to switch again. So advance the wire please in the distal part of the vessel. Yeah, okay. There we go. Test a bit. Please don't move the catheter because it's important to remain at the same position. Okay, a little bit of test. Okay, you see it's a huge vessel. Yeah,
Дайте
okay, go,
на,
push.
Yeah, we can go by walk, yeah.
да увели,
And pull back now a bit. Yeah.
на камерата на ангиографията.
Now you put it.
Не,
Little bit more
другото,
distal?
ангиото горе, горния, който да отиде вдясно.
Fantastic. Okay, if you don't mind, we are still again in position. And now we are going to go live again. Please do
Окей,
not touch
супер.
the patient.
Оставете ги така.
Do not touch the patient. Make sure that the
И на
PA and
горния
the
екран сложете, Валери.
PA and PD are visible. And in the meantime, Tabo and the nursing staff here has changed the programmation of the pump. We are no longer give 10 milliliter per minute, but we are going to give 20 milliliter per minute. Okay? Ready to, you follow? We are going to zero the temperature to make sure that you see that the zero has remained very close to the zero, so there is no drift in temperature. That's very good news. You see that the PDPA is still the same, exactly the same as before, so we are all set, but no longer to infuse 10, but to infuse 20. This is something I can change here. And I will start the recording, tabs, whenever you want. Now, you can advance the reflow 1 millimeter or 2. We are infusing now. Yeah, that's fine. And you see that the temperature decreases much more than before. You see that? You also see that the PDPA changes. Changes to what? To 0.84. It will probably decline even a little bit more. And this is actually hyperemia. You are going to say, hyperemia, what do you tell us? Because we are not using papaverine here. Well, no. We know that administrating 20 milliliter per minute of saline through these lateral side holes induces the nicest steady state maximal hyperemia that you can dream of. And you see that all these numbers are extremely stable. There are some oscillations of the signal, but that's normal, that's the phasic flow. But on the average, it's very stable. And I will ask now, while recording, Valérie, to pull back again the wire in the exact same manner. Film this. It's better to film this. And 1, 2, 3, go. Go. Stop just this time. Stop. Oh, we are just off screen. That's not a problem. That's not a problem at all. You have seen that the signal has disappeared, but we have the values. They are here on the screen. Minus 8.5. It means that when you give 20 milliliters per minute across these ray flow catheter, when the saline arrives into the coronary arteries, it is minus 8 degrees lower than the blood temperature. That is what it means. And Tabo, now you can stop the pump. You see that the pump stops immediately. Sorry, Valérie, I'm in your way.
No.
The pump has stopped. There is no infusion anymore. And you see that the temperature goes back to the baseline. Very nice. And when we are back to zero, we are all very, very happy because it means that there has been no pressure drift. And I can stop the recording here. Okay? So you have everything just in front of you. And it's already I think I've done probably these recordings thousands of times, thousands. But still, I'm flabbergasted by several things. First, how stable these signals are, how reproducible they are, how perfectly, well, stable I told already, but look how these things are accurate, I would say, and precise. And you can go like this. And what did we see? Well, we see that the flow in the LED is no longer 166, but almost 500 milliliter per minute, which is not surprising. It's very high, but it's not completely impossible in a young gentleman with such a massive LED. Okay, and this is the hyperemic flow. Look at the resistances. They come from 700, they are down to 170. So a massive decrease, which is simply the translation of the vasodilation of the microvasculature. Then, if we go a little bit further, you see that we went from a gradient of, at rest, what did we have? PDPA of 0.94 to a PDPA of 0.84, which is FFR, by the way. So there has been an increase in the pressure gradient, which is the proof, the proof that we are hyperemic. And then there is a small detail which is so elegant, I cannot resist. Here, the pump is already giving 20 milliliter per minute. But the system is not yet fully vasodilated. And this is the reason why the temperature goes down even lower and then comes back. This square root sign is the proof that before you were at rest and afterwards here you are hyperemic. And actually you have seen we have waited a long time, because for educational purposes, but we could have stopped already here after 10 seconds, we were done. Okay? And this actually tells us that the 20 milliliter were delivered in a system which was not yet vasodilated, and therefore, of course, the temperature goes down much lower and comes back once it's vasodilated. So we have hyperemia, we just had rest, we can compare, and now we can, of course, calculate the coronary flow reserve. In absolute terms, we can calculate the microvascular resistance reserve in absolute terms. All these measurements, we will discuss that with the support of the slides. But I would say that's it. It's not more than that.
Impressive.
It's a very nice example.
Yeah.
There is a very small detail. Look at this. You see that how the lower the line, here, there is something which happened here with the signal. Why did it happen? Well, probably there has been, for some reason, a small bump in the pressure. You see how all these things go hand in hand, and you see how precise and accurate all these changes are. So we are no longer speaking of indicious and vague measurements, proxies. No, these are milliliter per minute. I will stop here. Thank you very, very much. Congratulations for your first absolute flow measurements.
Thanks.
And I think we can already say like this to the patient, that he can forget completely about microvascular disease. You remember that the IMR was 24. We said, it's a little bit high.
Borderline, let's say.
You know, when you have a microvascular resistance of 167, which is way below the value of 450, you can tell him, look, guy, there is really nothing special with your coronary arteries, except a little bit atherosclerosis. You have to be careful. But the microvascular function is strictly normal. So, thank you very, very much.
Thanks.
Thank you, guys.